Oops, I knocked that. Okay, so the next thing that we're going to talk about in this series is chapter 59 is the breast disorders. The biggest thing that we're going to talk about here is obviously breast cancer. There's a couple of other things that can go wrong with the female breast, but mostly what we are going to talk about and focus on is malignancies, because there's such a big healthcare concern. So before we get into the actual malignancies, there are a couple of things. Women can have fibroid tumors in their breast or cysts in their breast. Okay, that's nice. So fibrotic breast disease, it's benign, and it looks like, remember how I showed you with the female reproductive, like fibroids in the uterus? That can occur in the breast as well. Usually it starts occurring between the ages of 30 and 50. It's not malignant. There is some controversy about whether it predisposes somebody to developing malignancies, but most studies say that fibroid tumors don't necessarily lead to malignant tumors. Now, it is really important to know the difference between fibroid tumors and malignant tumors. So if you have an opportunity to palpate a fibrotic breast or a breast with a malignancy in it sometime in while you're a student, it would be really beneficial to you. Because it's so important to be able to identify these kinds of tumors, and also to be able to teach your patient how to do self-breast exam in order to be able to identify these different kinds of tumors. So here's the difference. The fibrotic cysts is usually, it can develop in one breast or two. They are typically more painful. A malignant tumor is not painful. Fibroids can move around, like they can grow, they can get smaller, they can move. Malignant tumors don't move, they're always in one spot. So a painful nodule that's palpated, like if you palpate this and find it and it is kind of sore, that's actually good news. It's probably fibroid. You don't know for sure till you get a piece of it, but it's probably a fibroid tumor, not a malignant tumor. So I already told you about that. So most of the fibroids are going to be circular, kind of like the ones that I showed you with uterine fibroids, kind of like these little circle balls. It's not going to cause the breast to look different. Malignant tumors will also often cause like nipple retraction or distortion of the nipple. Fibroids are not going to do that, nor will cysts do that. If you start seeing nipple retraction on the breast, that's not such a good sign. The malignant tumors typically are more irregular. They're not going to be that nice round nodule. They're going to be firm but not painful, and they don't move. They just kind of stay there, and they don't change with the menstrual cycle. Fibroids and cysts will often get bigger, smaller, move up with changes in the menstrual cycle. And usuly the lumps, it's not going to make one breast significantly bigger than another, especially in a fibroid kind of cyst. So one thing that we do as nurses is we, have to identify who's at risk for breast cancer and how do we prevent it. This is huge in healthcare and very significant for nurses. And so similar to the annual pap smear, we need our females to have annual mammograms, because detection is key. If we detect breast cancer early, we can save a lot of lives. So mammography is the best thing that we have right now to detect early malignancies. They are coming up with some new diagnostic procedures now. So if you're not familiar with a mammogram, is a woman goes in and the breast is placed basically on like it's almost like an x-ray table, and another kind of x-ray thing comes in. They smash the breast. Most women don't find this very comfortable. Between two, what would be like x-ray plates, and then they just get an x-ray of it. I'm going to show you what that looks like. But they're coming up with some new ones now where like women can lay in water, and they do like water, like sonogram, like the water waves. So they're coming up with some better techniques, but right now mammogram is the diagnostic procedure of choice. And it gives us a really good that you can survey the breast, you can monitor them over time. So, you know, in like subsequent years, if something shows up, you can go back and look at one of the previous years. Really important to get annual mammograms. So there are a lot of agencies. So if a patient does, if they're worried about it, if they've got a family history of it, there's a ton of resources for women who have breast cancer, they're worried about breast cancer, things like that. So the one thing I did want to talk about is the different kinds of breast cancer. Most women who develop breast cancer do not have a genetic mutation. These kinds of cancers typically show up in women, you know, over the age of 65. And if it's early, if it's detected early, they find it on mammogram, and they can remove it. It's usually a fairly easy cancer to treat. They can go in, they take it out, do a lumpectomy. They will check the lymph nodes, maybe have to have radiation, maybe have to have chemotherapy, but oftentimes that cancer is very responsive to cancer treatment. However, sometimes there can be a genetic component. It's called the BRCA gene, or the BRCA gene, and it runs on chromosome 17 or chromosome 13. You don't need to know that part. You just need to know that there is a genetic component called the BRCA gene, gene 1 or gene 2. These genetic mutations predispose women for breast cancer, and it predisposes them earlier in life. These are the women that show up in their 30s, 40s with a breast cancer, and that kind of cancer is very aggressive, and it needs to be identified early and treated very early, but the chances of surviving that kind of breast cancer is significantly less than if there is not a genetic mutation to it. So if a woman has a close family history, a mother, a sister, an aunt, a maternal grandmother, even a paternal grandmother, who has had breast cancer, especially if they've had breast cancer early in life, or ovarian cancer, and they've had several of them in the family, probably a good idea to get some genetic testing, and they might need to start treatment a lot sooner. These patients sometimes will get baseline MRIs early in life, like at 20, 25, 30. Might need to get some genetic counseling, much higher levels of surveillance. But for most of the population, your annual mammogram is going to be sufficient. You also want to teach your patients how to do an annual, or how to do self breast exam. Now there is a difference between a clinical breast exam. That is a breast exam that is done by a trained healthcare provider versus a self breast exam. So a clinical breast exam is done annually, usually when the woman goes in for her gynecological annual screening with a pap smear. Typically the gynecologist is trained, or the internist, whoever does their annual physical exam, is trained to do a clinical breast exam where they will examine all the breast tissue, palpate all the way around, and identify whether they actually feel any lumps, and then they'll evaluate that with the findings from the mammogram. That's called a clinical breast exam, not to be confused with the monthly self breast exam that your female patients should be doing at home. I'm going to tell you about that in a minute. So usually younger women, they don't need to really have a clinical self breast exam annually. You might want to start that, you know, a couple 3 times before they turn 40, but standard now, according to the American Cancer Society, is at the age of 40, then women should have an annual clinical breast exam included with their annual physical exam. Most post-pubescent females, these are women who have already started menstruating, and they have a family history of breast cancer, they might require different screenings. They might need to start an annual clinical breast exam earlier, or get an MRI or you know, genetic screening. But typically in most of the population, once a year after the age of 40, clinical breast exam. This is how you would teach your patient to do a self-breast exam. Self-breast exam should be done every month, usually 10 days after the period. The reason is you don't want to do it right before, like the week before a woman starts her period, because the breasts tend to get a little fuller and they're more painful, so we don't want to do that. You don't want to do it during the period, but usually 10 days after the start of the period. Once the period is done, 3 to 4 days after that, great time. You teach your patient to get in a shower when their skin is all slippery. They're going to rotate the entire tissue, then pull down and then pull in and out. And what you're teaching your patient to test for is any lumps, any nipple discharge, any nipple disfigurement, anything like that they're going to want to notify their physician right away. Then you're going to want to teach your patient to just stand in front of the mirror, and the thinking now is just breast awareness. Make sure that your female patients are fully aware of what their breasts should be looking like. So then if there's any dimpling or changes that they can be aware of it because they know what they look like. Then you're going to want your patient to stand with their hands up. What this is doing is also stretching the muscles. You're looking for any lumps underneath the arms. A lot of malignancies will start up in this region. Then you're going to want her to put her hands down, and again what you're doing is you're just adjusting the muscle and the structure. And then you're going to want to have the female patient lay down, put a small pillow under her back, and then do the same self-evaluation while the patient is laying down. Important to teach your patient to do this every single month, because any little anomaly can be identified early, and with early detection, then we can prevent lives or save lives. Another thing that we want to do in our patients, which has been found to increase the risk of breast cancer, is high-fat diet. So this is another reason we're seeing an increase in breast cancer in the United States, is because the U.S. women love our fatty foods. So it has been shown that if you can keep your weight within 20% of the recommended body mass weight, then there is a decrease in the female's chance of breast cancer. Overweight women tend to get breast cancer more than women who are not overweight. And again, get a baseline mammogram done between the ages of 30 and 40. Again, might have to be earlier if there's a family history, but typically age between 30 and 40. And then, like I already said, 7 to 10 days after the menstrual cycle. And new findings, new anomalies need to be reported immediately so that we can begin treatment. This is what a mammogram looks like. So what they do, now this is a very dense breast. You can't see through it. They're not all this dense. But what they're looking at is you've got a lot of the mammary ducts coming in through here. And you don't need to know about all these different ligaments, but you got a little bit of subcutaneous fat here. But this is completely normal. There's no lumps. There's nothing identified in here. But now look at this. These are two mammograms. Both of them have invasive ductal carcinoma. The ducts, the mammary ducts, is a great place for cancer cancer loves to start in the ducts. So you can see this is a mammogram. These breasts are not as dense. You can see a lot through them, but you can see these malignancies are starting up in here. Not good. Those are not good. And that would alert the physician that there's a problem. So the radiologist would look at this, would notify the physician. The physician would then call in the female patient and start treatment. You can see smaller breast here, not as dense, you got a problem here. Another one, got a problem here. There's a big problem here. There's a smaller problem up here, a larger, denser breast, but there's still, you can see where that white one is right there, those are all problems. You cannot look at a mammogram and say, yes, you've got breast cancer, but what you can look and say is we need to do follow-up, and then you would go in and do a biopsy. You would have to go in, it's called a stereotactic biopsy. You keep the patient very still and go in under radiography, so you know where you're going in, and get a piece of that and find out what are you dealing with. You have a fibroid here, do you have something that you need to be a little bit more concerned about? If, I already told you that, if you've got a dimpling of the breast, this is a new finding, could indicate that there's something a little bit more serious there. You're going to take that to your the physician right away. So how do you know? How do you know what you're dealing with here? You've got to look at your prognosis. So when I say what's the prognosis, that means what is the likelihood of survival and how long is the likelihood of survival. So there's two things that are really important when you're talking about breast cancer prognosis. One, are any lymph nodes involved? So if you find a tumor and they go in and they remove that tumor, when the surgeon is in there, he or she will also take out the surrounding lymph nodes. If there's cancer in the lymph nodes, the prognosis is worse. The patient's probably going to need chemotherapy. If all of the lymph nodes are clear, prognosis is really good, and they may not even need chemotherapy. They might not even need radiation. Depends on what that malignancy looked like. And also the tumor size, smaller is better. So if you've got a small confined tumor with no lymph node involvement, that's a better scenario. And remember, we use the TNM system. T stands for tumor, N is for nodes, meaning lymph nodes, and M is for metastasis, has it spread. And those get worse the more it is. The bigger the tumor, the more nodes, and if it is metastasized, prognosis is worse. So that's how we know how bad the breast cancer is. Again, if the patient is overweight, if they are older, if they have a family history of it, all of these play a role in the risk and the development of breast cancer. So getting a good history with your patients is extremely important, because it has everything to do if this is like a small, we don't need to be as concerned about it, versus this could be a problem. There's a huge gamut when you're talking about breast cancer. Another problem that we worry about in our patients is this: if the breast starts getting this orange peel appearance, it's called a peau d'orange. And you'll notice in both of these breasts here, notice how the skin looks like an orange. It's got these dimplings in it. This is an ominous sign. These women did not get the treatment that they needed when they needed it. Because you can see here, see how the skin, especially on this breast, it's starting to pit. The nipple looks very, very unhealthy. It's dark, it's scarring. You've got some dimpling going on here and here. And it's causing this pocking kind of appearance. The problem is there is a malignancy growing. You see how the nipples are retracting in here too? There is a malignancy in here, probably causing blockage of the lymphatic system, because there's a ton of lymph nodes in here. And this is a stage of pretty advanced cancer. I'm guessing both of these women did not get treatment because they still have their breasts. And unfortunately now that's pretty advanced disease. So how do we fix it? What do we do about it once we identify that our patient does have breast cancer? Chart 58.8 is great for that. I want you to look at that in your textbook before you come to class. Typically, if they find a malignancy, they will find a mass on mammogram. They may, or you or the patient may or may not be able to feel it. Then they will do a biopsy to figure out what they're dealing with. If it is confirmed that it is malignant, they will remove it surgically. And that's either a lumpectomy, it could be as simple as a lumpectomy, to a radical mastectomy. I'm going to show you a little bit about that. And they can do a lot of, you know, flap reconstruction, things like that. They could then do radiation therapy, especially if it's invasive, if it's starting to invade different lymph nodes, spreading out through the ducts. They might do radiation therapy. Remember with your patients who have radiation therapy that the side effects of radiation therapy will occur at where the radiation is going. So if it's radiating at the breast, you're going to have some skin excoriation at the breast. It would be like a sunburn. If it's near the mouth, your patient's going to have sores in their mouth. So radiation is a beam that is sent to a direct area, whereas chemotherapy goes IV, and that goes everywhere. So it's going to affect all of the fast-acting cells, which is why the patient who gets chemotherapy loses their hair. They can lose their fingernails, they can get sores in their mouth and have diarrhea because the GI tract flips over rapidly every 3 days. So those, nausea and vomiting because your GI tract flips over every 3 days. So those are the difference if your patient is on radiation versus chemotherapy. Some things to keep in mind. Okay, so I told you about the rest of that. This is a lumpectomy. So let's say that they found a lump up here. They have gotten a piece of it in a biopsy, identified that it's malignancy. They can go in here and just take out the entire lump. The pathologist would then test all this tissue around here. And if all this tissue around here is clean, then the surgeon knows that the carcinoma has not spread out, and sometimes that's it. Sometimes they don't even need radiation or chemotherapy. You would watch this patient very closely, but sometimes that's all they need. Now, if it has gotten close around here, they might want to also just sort of radiate. Usually when they're in there, they'll come and get some lymph nodes too, and if those are all negative, then the patient's good to go. This is actually a really great scenario. However, sometimes the cancer is so significant and it has invaded that the patient has to have a radical mastectomy. Now, some people who have the BRCA gene have chosen to have preventative bilateral radical mastectomies, most famous being Angelina Jolie. Angelina Jolie, a couple of years ago, identified that she was carrying the BRCA gene. She has a mother and sister who's had breast cancer. I think an aunt has had ovarian cancer. She got tested. She did have the BRCA gene, so she chose to have bilateral mastectomies because her risk of getting breast cancer was significantly high. So she went ahead and did that ahead of time. The nice thing now is that they can do a lot of reconstructive surgery. They can do a thing called a tram flap, where they remove the breast, then they remove some skin from the abdomen, they pull up some muscle, and then they reconstruct the breast from this skin and rebuild the breast, because self-image is huge. Obviously, breasts are something that make a woman feel feminine, and when those are gone, then all of a sudden that is very significant for her level of self-confidence and self-image, because this is what a female looks like with bilateral radical mastectomies. And so now, without the reconstructive surgery, she's going to feel a lot like a man. Now, if she does not want to go through the extensiveness of a tram procedure, because it's a big surgery, they do have a lot of things, like they've got bras now with built-in artificial breasts that women can wear, but it's more external. So then, you know, when she is, you know, naked by herself, she's going to look a lot more like this. People out in public aren't going to know if she's got clothes on and stuff. But so that's something you just want to talk about with your patient. Also, when they can rebuild, sometimes what they can do is insert implants, just like women who get you know, breast implants and breast enlargements. This is how they do it. So they go in this muscle right here, they implant, there's all saline filled now. They used to not be saline filled. Most of them are saline filled, except I heard that some of them are going back to silicone because silicone is more of a natural feel. The problem was with the silicone implants is that they would leak and cause a lot of problems. Saline doesn't cause any problem. It's just like, you know, the saline that you infuse IV. And what they do then is they can adjust this to make it however big, you know, the person wants. This is the same procedure they do for women who are getting breast implants, but they use the same procedure for women who are getting reconstructive surgery for following breast cancer. So this is the tram procedure. It's not yet completed. They have not yet restored her areola. And what they do with that, but they've done the tram procedure. They brought the muscle up. This is from her abdomen, and they put the implants in. So they're starting to give her a more feminine look now. And then this is where they go in and they will reconstruct the areola. And sometimes what they can do is just some tattooing, some light tattooing. But you know, the plastic surgeons are great about building this up, and now they have restored this woman to a natural, you know, feminine appearance. So this can really help women who have experienced, you know, the trauma of losing a breast to breast cancer. So they can do some really great things. So if you're not familiar with radiation chemotherapy, study this. I don't want to, you know, beat that to death. I feel like we really talked about that. Another thing I do want you guys to know about is lymphedema. Lymphedema can occur. Now you'll notice that this woman has had surgery up here. So she's had a mastectomy. The problem with your patients who've had mastectomies is the lymphatic system. You get a ton of lymph nodes in the axilla. So it is very common following breast cancer surgery that this lymphatic system doesn't drain very well. And then you can get extreme lymphedema. So you need to be very careful in your patients who have had breast cancer, and especially who have had surgery, either radiation, chemo surgery in here. Do not take blood pressure in this arm. Don't take, you can't draw blood in this arm. Many of them will have a sleeve on. It's like almost like an ace wrap to get the lymph to flow back down, because this is a complete blockage of the lymph. That's called lymphedema. And one way that we can prevent that is by getting your patient to do post-operative exercises, because you want to keep this arm moving. You want to keep that entire lymphatic system open. So you know, just have your patient move by brushing their hair. They can attach things to, you know, door handles. An easy thing to do is just have your patient walk their hand up and down a wall like that, and gets that arm moving up and down. And you're constantly, and the rest of their life, they need to do this the rest of their life, because lymphedema can occur at any time following a mastectomy. So that's really important in your patients that have had surgery for breast cancer. So that's what I want you to know, because breast cancer is affecting so many families and so many lives. And so us as nurses, we want to support the women going through breast cancer. We want to support the families who love the women who are going through breast cancer, early identification, early treatment, and hopefully we can save lives. So that's what you need to know as a nursing student. Okay.